Warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Dear students of fourth year MBBS, today we will discuss bacterial, fungal, and acanthamoeba keratitis. The learning objectives of this lecture are: we want to know the symptoms and clinical features of bacterial, fungal, and acanthamoeba keratitis, and we want to know how will you diagnose and manage the cases of bacterial, fungal, and acanthamoeba keratitis. Bacterial keratitis usually develops when ocular defenses have been compromised, but the certain organisms like Neisseria gonorrhea, Neisseria meningitidis, Clostridium diphtheria, and Haemophilus influenza are the bacteria which can penetrate healthy corneal epithelium. And the other bacteria which are responsible for bacterial keratitis are Pseudomonas aeruginosa. These are gram-negative bacilli present in soil, vegetation, and in hospital moist environment. Staphylococcus aureus is the gram-positive cocci present in nares, skin, and conjunctiva. And Streptococcus pyogenes are gram-positive cocci present in throat and vagina. And Streptococcus pneumoniae are gram-positive organisms present in upper respiratory tract normally. The certain predisposing factors which whenever present in certain individuals, they are more prone to have bacterial keratitis. And the individuals who are used to have contact lens wear, they are more prone to have bacterial keratitis, particularly the Pseudomonas, as they cause hypoxia of the epithelium and the epithelium is no more healthy. Similarly, the trauma, it may be a trivial trauma causing the denudation of the epithelium. Normally, the normal organisms cannot penetrate the healthy epithelium, but once the epithelium is denuded, they can penetrate into the substantia propria, causing the bacterial keratitis. Certain pre-existing corneal diseases like ocular surface diseases causes derangement of the corneal epithelium. Chronic blepharoconjunctivitis and similarly the tear film deficiency. The normal tears are essential for the nutrition of the epithelium. When the individual is having tear film deficiency, as in dry eye, the corneal epithelium does not remain healthy. And moreover, certain elements are present in the tear film. They are bactericidal and bacteriostatic. And the immunoglobulins are also present in the tear film, which protect the individual from infections. Similarly, hypovitaminous A, the vitamin A is required for the normal healthy epithelium. And the topical steroid use. In injudicious long-term use of the topical steroids invites the bacterial keratitis. In this picture, you can see the different stages of the corneal ulcer. Can be divided into three stages: progressive stage, regressive stage, and healing stage. In first picture, you can see the gray zone infiltration of the polymorphs, localized necrosis and sloughing, and you can appreciate saucer-shaped ulcer with overhanging edges. But in regressive stage, corneal edema subsides, dead material thrown off, and the floor and edges of the ulcer are smooth. And in healing stage, superficial vascularization near limbus starts, formation of fibrous tissue is there, and ultimately cornea become opaque. and the opacity may be of different. And the clinical features of the bacterial keratitis are the generalized symptoms are foreign body sensation, photophobia, blurring of vision, and pain as the epithelium is involved. These are the generalized symptoms as in any disease which involve the epithelium. Now come to the signs which you see when you examine a patient with a bacterial keratitis. Of course, whenever there is a corneal involvement by any disease, you find conjunctival and particularly the circumcorneal congestion. Epithelial defect may be there. If stroma is involved, then the stromal edema, you can find the stromal edema and folds in descemet membrane. If secondarily uveitis is there, you will see the signs of uveitis. Their hypopyon may be present with posterior synechia in moderate to severe keratitis. If the corn ulcer continue to progress, it may deepens and superficial stroma is trough off, and the descemet forms the descetoceles outpoaching of the descemet membrane. And ultimately, this descemet membrane gives resistance to the perforation. But if the infection continues, ultimately perforation may be there in severe keratitis. And endophthalmitis, in which case the bacteria penetrates into the eye and involving all of the layers of the inner layers of the ophthalmic ball. But it is rare in absence of perforation. Once perforation is there, bacteria penetrates in the eye and causing the endophthalmitis, and ultimately the corneal vascularization in the healing process. What are the complications of corneal ulcer? Corneal ulcer may, along with corneal ulcer, there may be interior uveitis may be present, secondary glaucoma, and descemetocele in case of continuous sloughing of the superficial and deeper layers of the substantia propria, and then of course this descemet membrane form outward protrusion that is called descemetocele, and ultimately perforation of the corneal ulcer occur. Once the perforation of the corneal ulcer occur, it causes iris prolapse, cataract formation, endophthalmitis, and panophthalmitis when outer layers of the eyeball is also involved. Intraocular hemorrhage may be there. Retinal detachment due to the sudden lowering of the intraocular pressure, it may give rise to retinal detachment. And the anterior synechia, peripheral portion of the iris, sticks to the posterior part of the cornea that is called the anterior synechia. And ultimately, when the corneal ulcer heals, it gives the opacity. Whenever Bowman's membrane or the structures of the substantia propria are involved, healing is bound to occur with corneal opacity. Corneal opacities are of three types: nebular corneal opacity, macular corneal opacity, and leucoma. In nebular corneal opacity, very superficial part of the substantia propria is involved. In this case, the rays can pass through, certain rays diffract and certain pass through the cornea. In the case of macular opacities, the superficial part and the middle parts of the substantia propria is involved. But in case of leucoma, there is a dense corneal opacity through which the rays cannot pass through. And ultimately, the cornea become vascularized in severe cases of corneal ulcers, limbal vascularization, along with which penetrates towards the center of the cornea. In this picture, you can see the corneal vascularization along with corneal opacity. In this picture, you can see the corneal stromal infiltrates in early bacterial keratitis, where the polymorphs penetrates into the superficial corneal stroma. In this picture, you can see that the denser layers of the corneal stroma is involved, giving rise to the whitish, dense white appearance to the cornea. Here you can appreciate in this picture hypopian corneal ulcer along with greenish yellowish ulcer, usually in the Pseudomonas aeruginosa. And this Pseudomonas aeruginosa ulcer rapidly causes melting of the cornea. That's why it is very serious keratitis. In this picture, you can see the dense white suppuration of the substantia propria with hypopion. It is usually due to the streptococcal infections. White appearance, white sloughy appearance is due to the streptococcal infections. In this picture, you can appreciate the generalized whitish, angry looking picture when the inner portion of the eyeball is involved, giving rise to the endophthalmitis. Now come to the investigations. How will you investigate a case of bacterial keratitis? Whenever you come across a keratitis, you take the corneal scrapings, conjunctival swabs, and the contact lens, its solutions of the bottles and contact lens itself. Then you do the gram staining and culture and sensitivity. On blood agar, 5 to 10% sheep blood, and on chocolate agar, cells lysed by heating. In gram staining, you can appreciate in the upper picture A, gram-positive cocci, they are Staphylococcus aureus arranged in clusters. In picture B, you can appreciate gram-positive cocci, they are arranged in pairs and chains, they are Streptococcus pyogenes. And in picture C, you can appreciate gram-negative bacilli, they are Pseudomonas aeruginosa. And these are pictures are on the gram staining. In this picture, in the figure D, you can appreciate the culture media. In the picture E, you can appreciate Staphylococcus aureus on blood agar forming golden colonies. And in picture F, Neisseria gonorrhea on chocolate agar. Now come to the management of the keratitis. Once you have taken the swab and done the sent for gram staining and culture sensitivity, then you start the treatment. You start the broad spectrum topical antibiotics. You may start with monotherapy, only using the cephalosporins, ciprofloxacin, ofloxacin, or dual therapy. In dual therapy, you use the fortified antibiotics, usually gentamicin or tobramycin in 1.5% concentration, and cefazolin, cefuroxime, or ceftazidime in 5% concentrations. These concentrations are not available in market. You prepared with from the injections yourself and use topically. initially very frequently, then depending upon the response of the treatment, you tapered off and come to the normal concentration, that is 0.3%. If these are not working and infection is very severe, you can give the subconjunctival injections. Vancomycin or amikacin may be used. You can use the systemic antibiotics wherever you suspect the severe infections, and always use the topical cycloplegics. And atropine is the strongest cycloplegics. It gives comfort to the patients and rest to the silly body. We use the systemic antibiotics when there is a potential for systemic involvement is there, particularly in Neisseria meningitidis, in Haemophilus influenza, and Neisseria gonorrhea. In Neisseria meningitidis, we use benzyl penicillin, ceftriaxone, cefotaxime, or ciprofloxacin. In Haemophilus influenza, we can use the augmentin, and in Neisseria gonorrhea, ceftriaxone is the drug of choice. Whenever we find extreme corneal thinning and melting, we use ciprofloxacin and doxycycline systemically. To promote the healing of the corneal ulcer, it is necessary to promote the epithelial healing. That can be promoted by taping lids temporarily, causing central tarsorrhaphy with the help of bandage contact lens in small perforation. You may use the amniotic membrane graft or the conjunctival flap and the tissue glue under bandage contact lens, particularly for small perforations. In this picture, you can appreciate in picture A, a temporary taping of the lids is done, and in the second picture, we have done the central tarsorrhaphy. In this case, the constant rubbing of the lids, which causes the derangement of the epithelium and does not allow the epithelium to heal, we stop that. And the picture C, we have the conjunctival flap. This is the Gunderson conjunctival hood flap. And picture B, we have used the bandage contact lens in an eye with a small perforation. And that perforation is, it promotes the corneal epithelial healing, and the perforation is sealed later on. In this picture, picture E, you can appreciate the amniotic membrane graft. That graft is placed on a perforation and stitched to the cornea. And ultimately, once the ulcer is healed, we remove this amniotic membrane. In other picture, you can see the tissue glue under a bandage contact lens in an eye with a severe thinning. Once the epithelium is healed, we can slough off the superficial portion and the cornea become clear. What are the causes of failure of the treatment? It may be the wrong diagnosis. It may be the incorrect treatment. Or sometimes the corneal ulcer might have healed, but it is the drug toxicity which does not allow the epithelium to grow over the healed corneal ulcer. So once the corneal ulcer refuses to heal, you do all the steps of diagnosis, again take the scrapings, send for culture sensitivity, and ultimately if even you can take off the portion of the cornea for histopathology. This is all about the bacterial keratitis. Now we will discuss the fungal keratitis. The fungi are microorganisms having rigid walls, distinct nucleus containing both DNA and RNA. Two types, commonly filamentous fungi and non-filamentous. And filamentous fungi are Aspergillus species and Fusarium species. And filamentous fungi are multicellular. They produce tubular projections called hyphae, and they are common in tropical areas. And non-filamentous fungi are called Candida albicans. These are unicellular. They reproduce by budding method, and they are common in temperate areas. And certain predisposing factors, as in case of bacterial keratitis, in this case, the chronic ocular surface disease causing the abnormality of the corneal epithelium, long-term use of steroids, similarly the contact lens wearers, and the individuals who are working in fields having trivial, maybe a trivial trauma with the vegetative injuries in the agricultural areas. So the trauma with the vegetative matter is important in the history. And pre-existing corneal diseases and the individuals who are immunocompromised have more prone to have the fungal keratitis. So what are the clinical features of the fungal keratitis? The generalized symptoms of the fungal keratitis are the same as any disease involving the cornea, but in this case, there is a gradual onset of mild to moderate pain. Foreign body sensation and photophobia and blurred vision may be there, and discharge is very, very scanty. And this disease progress slowly as compared to the bacterial keratitis. In this picture, you can appreciate fungal keratitis involving the superficial portion of the substantia propria along with hypopyon. In this picture, a fungal keratitis with satellite lesions. You can appreciate the main lesion and the satellite lesions, which are a hallmark of the fungal keratitis. Now come to the signs of the fungal keratitis. In filamentous keratitis or the fusarium forms, you will find gray stromal infiltrate with dry texture and surrounding satellite lesion with immune ring along with the main lesion are usually present. Endothelial plaque and hypopyon may be present. In this picture, you can appreciate grayish-white lesions along with satellite lesion and keratitis in case of filamentous fungal keratitis. In this picture, you can appreciate grayish-white lesion along with satellite lesion. That is a case of filamentous keratitis. And in case of Candida infections, non-filamentous keratitis, you can see the yellow-white ulcer and dense suppuration may be there. And in certain cases, when the Candida penetrates into the inner of the eye, they may involve the vitreous, forming the cannonball appearance. How will you investigate a case of fungal keratitis? Here, we do the staining with potassium hydroxide, Gram and Gimza stains, and periodic acid skiff and chalcofluor white and methanamine silver stains. And this chalcofluor white and periodic acid skiff stain have a peculiar affinity to the fungal keratitis. And we do the culture with Severod agar. Polymerase chain reaction may be helpful, and even then, if you have the doubt in the diagnosis, you can take the biopsy of the cornea for histopathology. So what is the treatment of fungal keratitis? Once you have taken the smear for staining and culture, then we do the general measures as we do in the bacterial keratitis, and we want to promote the corneal epithelium healing with the general measures as we have discussed in case of bacterial keratitis. We may debride the corneal epithelium to remove the load of the fungi. Then we use the topical antimycotics. In filamentous keratitis, we use netamycin 5%, iconazole 1%, amphotericin 0.15%, and miconazole 1%. In case of candida, we use the topical antifungals, netamycin, iconazole, amphotericin, fluconazole, miconazole, or flucytosine. We can use subconjunctival fluconazole in case of candida and filamentous keratitis both. And broad spectrum antibiotics, topical antibiotics are used along with antifungals to curb the superadded bacterial infections. So in treatment, we always give the cycloplegia to give the rest to the eye and to make the patient more comfortable. We can use the systemic antifungals when we are suspecting the severe infections, particularly when the lesion near limbus is there or it is involving the sclera. We can give the voriconazole 400 milligram twice daily one day and then followed by 200 milligram twice daily. Fluconazole can be given 200 milligram twice daily, and tetracyclines, particularly the doxycycline, 100 milligram twice daily if there is a significant corneal thinning is present. Always monitor for intraocular pressure and cater for perforation. Whenever this keratitis continue mm, growing, causing the sloughing of the substantia propria and not responding to the treatment, perforation bound to occur. So we tackle the perforation as we have discussed in case of bacterial keratitis. We can use the superficial keratectomy. This remove the superficial slough so that this fungal load is reduced and antifungal drops may be helpful now. And if the treatment fails, we can use the therapeutic penetrating keratoplasty if the ulcer refuses to heal. This was all about the fungal keratitis. Now we will discuss the Acanthamoeba keratitis. Acanthamoeba is a unicellular free-living protozoa. It is found in soil, fresh or brackish water, and upper respiratory tract. So it is present in two forms, cystic and trophozoite form. Its cystic form is highly resilient. It can tolerate extremes of weather, extreme high temperature and low temperatures. So this Acanthamoeba keratitis is an opportunistic organisms. Whenever there is derangement of the epithelium is there, particularly with the minor corneal abrasions, or the individual is wearing the contact lens which causes the hypoxia of the corneal epithelium, so the epithelium is no more healthy, or the patient is immunocompromised patients. You may find the history of swimming in these patients, particularly with the contact lens wearing. So what are the clinical features of the Acanthamoeba keratitis? The symptoms are blurred vision and very severe pain, which is inconsistent with the findings of the corneal lesions. And as far as signs are concerned, you may find limbitis, involvement of the limbal, radial keratoneuritis may be there, as this Acanthamoeba keratitis involve the nerve endings in the cornea. Punctate or pseudodendritic keratitis may be present. Central or paracentral ring abscess may be seen, and satellite lesion peripheral to the ring may be present. You may find scleritis. So this scleritis is generally not due to the involvement of the Acanthamoeba. It is generally due to reaction to extension of the lesion, and corneal melting may be there. As the stromal disease, it penetrate into the stoma is involved and causing the corneal abscess and corneal melting. In this picture, you can find the pseudodendrites. In picture A, you can appreciate the pseudodendrites, epithelial pseudodendrites. And lower picture, there are anterior stromal infiltrates present. In this picture, you can appreciate perineural infiltrates in Acanthamoeba keratitis. In picture D, you can appreciate the ring abscess. And in picture E, the generalized opacification of the substantia propria. And in picture F, corneal melting along with the huge epithelial defect. So how will you investigate a case of Acanthamoeba keratitis? Investigations are general rule. We take the staining of the corneal scrapings and we do the staining with periodic acid calcofluor, white, gram and Giemsa stains. And then we inoculate these scrapings on the non-nutrient agar seeded with dead E. coli. And polymerase chain reaction may be helpful, and even if still the diagnosis is doubtful, you can take the corneal biopsy and do the histopathology. And what is the treatment of Acanthamoeba keratitis? To treat Acanthamoeba keratitis, first of all, high index of suspicion is needed. So you suspect the Acanthamoeba keratitis, then you can institute the treatment early. Early the treatment, better are the results. And debridement of involved epithelium is helpful. And then we use topical amebicides. Combination of propamidine with isethionate with polyhexamethylene bigionide 0.02% is helpful. Similarly, the combination of Brolin with neomycin can be used along with chlorhexidine 0.02%. And topical steroids to curb the inflammation may be judiciously used along with amebicidal topical drugs. To control the pain, as the pain is very severe in this case, it is inconsistent with the findings of the corneal lesions, we can use the non-steroidal anti-inflammatory drugs. And if all these measures fails and patient and corneal lesion refuse to heal, we can use the therapeutic penetrating keratoplasty. So this was all about the bacterial, fungal, and Acanthamoeba keratitis. Ladies and gentlemen, I am thankful to you all for patient listening. Now I am giving you the assignment. The assignment is how will you differentiate between bacterial, fungal, and Acanthamoeba keratitis in terms of symptoms and clinical presentation? And how will you investigate a case of corneal ulcer mention outline of the treatment. Please send your assignment to the given WhatsApp number and the email, and your attendance will be marked according to your response of this assignment. Thank you very much, dear students, for patient listening.